Welcome to a crossover webinar on virtual primary health strategies. We're excited to welcome you today. It's going to be an interesting webinar. Usually these tend to be directed more towards sales, and I just think we're at an interesting time now with virtual care where people are starting to believe that that there is some real promise that it can deliver primary care. And so we're going to go straight to the people that actually do that work, providers, and we've got a great panel today, and so we'll hear from them about their experience and their strategy in delivering primary care, mental health, and MSK care virtually. We'll give it just a minute, and then we'll advance. Donna, James, Nicole, you guys ready?
We are.
Awesome. You're looking sharp. It looks like you guys coordinated the backgrounds pretty well, except mine looks different, or maybe that's just because of my video reflection. Looks like I have my crossover logo on my right side, and you guys have it on the left.
No, it looks the same to me, I think.
Awesome.
It's just on your end. Otherwise, it comes across normal.
Well, good. Well, look, it seems like we're covering the basics. So, well, let's get started. I'm excited to have you guys. I think the world of you. I appreciate the care I get from you and the care that you deliver to the rest of the crossover employees. So I'm excited to take a few minutes and kind of listen to you guys describe your approach to care. So, one of the things I wanted to do as we start is some of you on the webinar have heard me speak ad nauseum on this book I read on from the National Academy of Sciences and Engineering about implementing high quality primary care. Tons of great quotes. I highly recommend it. But one quote that stood out to me recently was this: that primary care is the only component of healthcare where an increased supply is associated with better population health and more equitable outcomes. And I think it's probably fair to say that most of us on this call today either believe this statement or really want to believe this. The struggle is, how do we make it happen, and how do we scale it? And this is really what we're going to try to do today in talking about how we believe virtual primary health, and you might hear me say that, virtual primary health for us is the inclusion of primary care, mental health, MSK, health coaching, and care navigation. So it's bringing kind of a broader set of services together. But it's probably fair to say that a lot of us on the call want to believe that's true and have the hope that virtual is getting there, that it can deliver that promise to us. So we're as I highlighted them earlier, we're joined today by Donna, James, and Nicole, three of our leaders in our virtual primary care medical group. I want to give them just a moment to introduce themselves. Donna, why don't we get started with you?
Hello, everyone. My name is Danna Chung. I'm a board-certified internal medicine doctor, allergist, immunologist, and also integrative holistic medicine doctor. I've been in the virtual space for almost a decade now. I started with one of the pioneers of asynchronous virtual care, Sherpa, and then have worked for a number of other telemedicine companies and joined Crossover in 2019 whenever they acquired Sherpa.
Great, James.
Thanks, Nate. Hi, everybody. I'm Dr. James Marinchak. I'm a licensed clinical psychologist, and I'm the mental health lead for the virtual team. So I manage a team of psychologists on the virtual team nationwide. I've been with Crossover just over 2 years, going back to July 2020. And prior to that, I was at a VA hospital in the Veterans Health Administration, going back to my internship year 8 years ago. Background is working in health anxiety and health psychology and anxiety disorders, and really excited to be here with you. I'll talk about the virtual care model we have.
Great, Nicole.
Hi, everyone. I'm Nicole Liu. I'm a board-certified physical therapist and an orthopedic clinical specialist. I did a year-long orthopedic residency after physical therapy school, and then I worked on-site at Google for a few years. I joined Crossover in 2017, working on-site at Facebook, which is now Meta. In 2019, I pioneered the virtual physical therapy program here at Crossover Health, and I'm currently the physical therapy lead. And so we have 8 physical therapists across the nation working on our team. Happy to be here.
Awesome. Thanks, Nicole. Well, for those who don't know Crossover, let me just give you a little bit about our care delivery model. We're a national medical group. We've been around since about 2010. We deliver our care to large self-funded employers, large organizations that are really focused on their population and improving their overall health. The way that we organize ourselves is we operate in this care team model where all of our members are surrounded by a care team, a primary care doctor, a nurse, a mental health therapist, a physical medicine specialist, either PT, chiro, a health coach, and very importantly, a care navigator. So this care team comes together into this primary health service scope to help our members achieve better health. We have sick members, we have younger members, we have people like me, 45 years old, that are getting older and never used medicine before, and now I need to start worrying about it. So we have all spectrums of care that we need to serve. But when we do so from this care team perspective, then we're able to be comprehensive, coordinated with the care that we deliver. We deliver this care both physically and virtually across the country. Of course, here you can see a lot of our physical locations and where we plan to be. Our challenge, and probably similar to some of your challenges, is regardless of however many physical locations we build, there will always be corners where we don't exist. And we're a large national self-funded employer ourselves. And so as we think about trying to deliver care to our own employees, we have to think about how do we best get this advanced primary health model to them. And so as a core part of our foundation, virtual primary health has become really, really important. We organize ourselves from a primary health model in 4 different regions. We have care teams that are licensed in each region that are assigned to members in those regions to deliver care. That's to meet all of the state and regulatory requirements as a medical group. It also gives us that ability to kind of connect with our care teams. I actually live in Southern California. I'm connected to my care team, and I have a fabulous doctor. Had some awesome issues, as Danna knows, this year: potential tick bite, COVID, a nasty bee sting, and an annual physical, all managed by my doctor, and a couple of MSK injuries in there as well. But it's been fabulous to be able to connect to my care team repeatedly. What makes that possible is obviously having easy access to my care. So I use this crossover app, and I'll shoot a message to my doctor, John, and we'll go back and forth on the issue, whether it's a referral or a condition, and it's just super convenient for me, and that's kind of how I use it. There's a lot of details in how people access our care, visit links, the depth of the model, and some of those things we'll answer on this call. If there's things that we don't answer, feel free to shoot us an email, and we'll certainly go through the sales portion of the crossover model. But I don't want to delay too much in getting to our providers and talking to them about virtual primary care and virtual primary health. So with that, I want to dive into the questions. And actually, one more housekeeping item. To make this effective, it's really helpful to hear from you. I think this is a great opportunity where we've got 3 practicing providers delivering virtual care, and we'd love to know your questions. So we've got some people monitoring the chat function. Please submit your questions via that chat function. We'll try to grab them. We've got a lot of people on this call, but we'll grab those and try to work those into the discussion today. So Danna, Nicole, James, let's get started. One of the first questions that I get oftentimes, or in conversations that I have, is related to the depth of virtual care delivery. And they're really curious about how comprehensive can you be delivering care virtually. So maybe Danna, you can get us started, your thoughts on how comprehensive you can be with virtual care relative to physical care.
Sure. So as I mentioned earlier, I've been working in the virtual space for nearly the past decade. And so what has been something that has evolved even as a provider is coming to realize how comprehensive we can be in the virtual space, mostly because we have so many touch points that can be offered compared to the traditional medical setting. So we have a virtual solution that's staffed by employees. They're part of the same care team. A member who reaches out will engage with the same provider every time. So it's different than some of the other solutions out there where it might be disparate independent contractors or an AI algorithm and question bot that you first interact with. But so a member doesn't have to re-engage with a new provider, explain their background just because it's that provider on shift versus someone else. So we really want to make sure that, you know, we hit the ground running, and that once you engage with us, you don't have to repeat yourself, but that we can actually continue to sort of build upon your history each time and anything that you're dealing with. And so a lot can be done virtually, and some things even better because of the ease of access. And in our case, the way that we're structured to be able to do frequent asynchronous messaging in addition to the video visits. And so, you know, but I don't want to sort of say that virtual can always be the only solution. There are some times when you need to send someone to be seen in person. And so for that, we've also set up a way that we can make sure that if we provide you a referral into the community, that we follow up on the care that's received by that member, because we really want this to be your virtual primary care home.
Danna, you know, as a patient, you know, when we traditionally go to physical centers, you know, our experience as a patient is like they like, you know, take our blood pressure and listen to our heart, and like then they're doing something right based on those two values. Maybe they ask us some questions, but that's, you know, it's usually pretty brief, right? And so I think a lot of us have the context that the taking the vitals is like 90% of you formulating your opinion about what help we might need or what's wrong with us, and you're not really able to take vitals. Can you help us understand like what is really valuable in helping you form your opinion? And then what happens if you do need to take vitals? What do you do in that situation?
Yeah, so to give you a frame of reference, we're able to basically do about 80% of primary care virtually, because as all of us learn in medical school, most of good medical care involves on the medical history and the communication with your patient. And so if we're to be frank about it, a lot of the exam components when you walk into your doctor's office is actually because they need to satisfy billing requirements for the insurance versus actually being relevant to the care at hand. So if I'm going to bill a certain office code, I need to have like 2 vitals on and like 3 organ systems or things like this, but it may have nothing to do with actually what you're complaining about. And so that is, but at the same time, I don't have an office filled with people in the waiting room and I have 15-minute slots. I'm able to take a lot of time to ask you all of those questions and be able to really focus on your history, which is, again, how we get most of our diagnoses and evaluations completed. But we have tools. And so there are things that we can work with in the virtual space to obtain objective measures. Many members have access to home blood pressure cuffs, so we can help them get access to that. Over-the-counter tests are available now. A picture is worth a million, or is it 1,000 words, right? But probably with inflation now, it's like 1 billion words. So we're able to really take a look, and you know, I can get a great photo of a rash and be able to save you a visit into the office. And so if we need to send you for labs or radiology, we can do that easily as well. You know, I can't do a pap smear virtually yet. There are actually home swabs that are coming into development, but if that's the case, then I'm going to have to send you to a brick and mortar location. But again, like I said, that physical exam component will be completed, and we try to bring you back to have, you know, the comprehensive experience where, you know, if you get sent out, you come back and we make this your virtual home.
Yeah, and I can say with John, he needed some labs for me, sent me, I just went in there, got the labs done, and then he messaged me back and he said, "Hey Nate, your labs look awesome. There's actually, my labs are posted to my account. So if I was actually able to understand labs, I would know what they mean." But he just said, "Hey Nate, you're looking awesome. That's great." So it was helpful to have that offline and then have him understand those labs. James, let's jump over to you. You're a therapist. You provide help to people that are having anxiety disorder, depression, a variety of behavioral health related issues. How is it that you deliver care virtually versus in person?
Yeah, I think it's a great question. There's two areas for me that in my virtual practice have really just been enlightening with, I think, the benefits and the approach of the virtual model. One in particular, I think it relates to access. And it's access, I think, in a way that goes beyond just, sending a message to your provider and the quickness of response to get back. But I think it's the personal touch that members and providers are enabled to have through a virtual platform like we use. And what I mean by that is that, when a member messages myself or one of my team, whether it's an initial consult or even just, I think, for any kind of an administrative reason, they're getting a personal response back from somebody right away. They're not going through a call service. They're not having to call like a clinic lead or a host. They're not getting a voicemail or anything like that I think you might maybe traditionally see in a brick and mortar kind of a practice. They're getting this personalized touch of somebody who really is trying to understand them and work with them and message back to them and sort of meet them where they're at with what their care needs and their goals are. So that, I think, just that ability to be able to connect and engage with somebody in that manner has been really helpful. And another way I think that comes across virtually is through the therapeutic alliance and relationship. When we think of mental health treatment, the stigma that's attached to it, I think sometimes the vulnerability that goes along with reaching out for help. I know even in the mental health field that there's been skepticism of whether virtual therapy could be as effective in making somebody feel heard, understood, cared for, just when you're not physically in the room with them. And it's been amazing for me, I think, both in my own practice to feel the connection that can be established with a member over a Zoom or a computer screen. And really feeling that that relationship is sound, and in some ways, I think maybe also augmented over virtual practice. We've also seen that we measure this here at Crossover through something called a therapeutic alliance score, which is a measure that members fill out as they're receiving care from a mental health provider that basically asks them, how heard or understood do you feel? Are you aligned in your treatment care goals with your provider? And essentially, do you feel like you're working on aims that feel consistent with what you're looking for in your care? And we see with virtual that those numbers are, if not equivalent, sometimes better than what you would find in a face-to-face clinic. That's really been astounding for me to see that how well that translates the therapeutic relationship in a virtual care model.
Great, thanks, James. And Nicole, you're a physical therapist. You think about physical therapy, you think about machinery and electric stim. I think those are difficult to do online. So how does it work to deliver care virtually as a physical therapist?
Yeah, I think that virtual physical therapy is newer. It's newer for our field. I think in the last few years we've seen a lot of companies, especially during the pandemic, pretty much every physical therapy practice tried to pivot into virtual if they weren't already doing it, which most were not already doing it. I think that's a valid question. It's a question we get from pretty much everyone, including our members. Like, if we can't put our hands on our patients, if we can't provide these different modalities in person, like, are we as valuable as in-person care? And to Danna's point, right, like when we're evaluating members or patients, the number one thing is always going to be the subjective and forming like a therapeutic alliance with them and understanding what their problem is. And we're able to do really thorough objective evaluations also virtually. We have different tools that we use. We use a lot of screen sharing. We use MedBridge. We do a lot of demonstrations. We make sure that the person is in a location where they can move and we can see them. We have different ways of taking joint angles and measuring range of motion and strength. So we've really adapted to the virtual space, and we are able to provide full stack, full scope MSK care. So what that means is we treat all body regions, we treat acute to chronic pain. We can own any sort of MSK issues, and we're able to own it from the beginning, from like when they first start having the issue all the way through the end of their rehab. Of course, we can't do everything. I'd be lying to say that we treat 100% of MSK issues that walk through our door, but I do think that 100% of MSK issues can at least start with us. And if the person needs hands-on care, say they have like a pelvic floor issue and they need a women's health specialist, then we can connect them into the community and Oftentimes they'll go and see a provider for some manual care and then come back and see us to finish out their rehab. And so we make sure that we always close the loop on their care.
Yeah, that's excellent, Nicole. I know that my wife has been going to a physical therapist, and it's difficult to get in. And it's the typical community physical therapist, and I had her connect with Stephanie. And what was really cool is, like, next thing I know is, like, her phone's in the garage, and she's on the Peloton and looking at range of motion. And I think she really appreciated that because she was in the environment where where the pain was happening, and she found that to be super helpful. And again, there's some certain things that you guys certainly can't do, but for a lot of those things, those repetitive stress and the places where we're having those injuries, you're able to, like, be right there in the home or in the workplace to be able to address those things.
Yeah,
Donna,
that's right.
there's a
I think.
sorry.
Oh, sorry. I was just
Go
going to
ahead,
say,
Nicole.
I think we're able to do assessments exactly, in the place where people are having issues. So we do look at people's workstation setups, like if that's where they're getting carpal tunnel symptoms, we are able to watch people run. Like, we're really able to see every sort of injury in action. And I think that that's actually really valuable. And in some ways, it's a benefit that something we're not really able to do in clinic always is reproduce people's symptoms. Like, sometimes in clinic, you just can't reproduce it because it's a different environment. Whereas at home or wherever they are, we're almost always able to reproduce the feeling that they're having.
Great, thanks. Donna, there was a question that came in on, physical exams and things that you need to touch in physical exam or do. How do you solve for those with virtual care? You might be on mute, Donna.
Sorry. So most things that present physically will have symptoms associated with it. So it can be a little bit more of a targeted exam. We are able to hop on a Zoom and be able to take a look at, do a neurologic exam actually via Zoom, be able to do an assessment of musculoskeletal, just like Nicole mentioned. There are times though, right, the concern that everyone's always worried about, what if there's something, we have no symptoms and it was only found incidentally on exam? And so I think that, the next step after a thyroid nodule, for instance, if that were to be found, would be an ultrasound. And so a lot of it is members perhaps presenting saying, I feel something here, and then we can go ahead and get you the next step for evaluation. It is one of those things where there's always going to be some concern of whether or not you might be missing something, even in the brick and mortar practice, which is why certain things like full body MRI scanning has been like resonated with some people, because they are always worried about the possibility that something will be missed. But usually members will come to us with some sort of symptom or some finding or something like that. And in addition, a lot of times, because of the ease of access, they'll come to us along the way for multiple things that they may see that they wouldn't necessarily have scheduled an appointment to go in and be seen, because they might have just waited for it to become more of a problem.
Yeah, I actually agree with that. Because of the simplicity of access, I know that in the last year that I've been connected, I've connected 5 times by my choice. I haven't connected with the doctor in like the last 15 years because it's hard to get an appointment. And now that we make crossover available to crossover employees, I just find it way easier to connect on simple things. And so ideally, some of those physical presentations of issues are brought to you, and then you're able to take it down the right path. But again, we're not able to solve everything, but it does put us in on notice, and we do have tools to be able to solve those things. Mm-hmm. Let's jump on. You talked about connecting live via Zoom, all of you guys actually, but there's also this other topic of asynchronous or messaging. I think healthcare is really good at introducing new words like synchronous and asynchronous, and we're starting to see that more in news articles these days. And so I wanted to bring a little bit of attention to that related to virtual care. So there's obviously, I can connect as a member to crossover, and I can schedule an appointment live and have a visit with Donna live or Nicole live, but I can also just start a conversation and message into you. So how do you guys use live conversations with your patients and members versus messaging? And maybe James, we start with you.
Yeah, it's really cool. This is one where I sort of feel like, at least from the mental health side, we kind of let our members' feedback and preference guide us with this. And what we found really is that members seem to prefer, I guess, what you would maybe call like a hybrid model, but one in which I think initially, through some initial messaging engagement, they prefer to meet with their therapist, their provider, synchronously, maybe for a first visit or a first couple. And I think in a way, just to really get a sense of, well, who is this other person that I'm talking to? To sort of put a face to the name, learn who you are, hear your approach and your thoughts on care goals. And then I think once that relationship, again, going back to that, has been established virtually over live meetings, that's when they seem to be a little bit more, I think, amenable to, oh, we can sort of deliver care asynchronously through messaging, or we've developed these what are called I treatments, internet-based cognitive behavioral therapies for things like depression, anxiety, substance use, that we can actually send modules to members to engage in care with. And the really cool thing about those, I think, is once you've actually established that relationship and sort of talked about it, made your care goals, and I start sending those modules back, they're not just this cookie cutter, one size fits all like forms that you send and then the member has to do it on their own. There's all these prompts that are involved in them that say, give us feedback, message your therapist back, send them this worksheet so that your provider can not only look it over, but actually give you written asynchronous feedback back on what you're doing. There's also flexibility to meet synchronously in the middle of delivering asynchronous care. So it's really not like a one size fits all approach, but again, it's sort of meeting the member where they're at. One other piece, if I can, that I've noticed is that especially with the population that we treat, many of them tend to be younger professionals, they're employed full time. They have young families, young children. And so I think that the idea of like getting to therapy, whether that's virtual or in person, that the travel time, the 45 to 50-minute session coming back, like it can almost make therapy start to feel like it's an added stressor. And that's not good, right? Because you're kind of coming there for obviously, hopefully some stress relief. And so sometimes the option for asynchronous messaging really meets our members where they're at just in their phase of life, where it's like, I can write back, I can engage in care on my own pace at my own schedule, and not one where I have to make it feel like it fits into everything else going on in my life.
Just a quick question. What % of your patients choose to connect with you live versus doing some type of messaging exchange with you?
Yeah, in the beginning, live, it's really high. I'd say probably like about 90% of patients in the beginning say, I'd like to meet with, for an initial synchronous visit, at the beginning. When we get to that like session 2, session 3, session 4 point, I think that's where we actually probably start to get closer to that 50% in a hybrid model of live and async. We have a small percentage, maybe about 15 or so, that will say, okay, that eye treatment sort of asynchronous only approach works for me. But we kind of get more to, I think, about like a 45 to 50% where they prefer that hybrid model.
Gotcha. Nicole, what about you? How do you, balance live versus messaging? Or I should say, how do your members prefer to consume you? Live messaging? What's been your experience?
Yeah, ours is probably pretty similar to what the mental health team sees. We always offer a video visit to start to be able to see the member and form a relationship and do an objective exam, kind of like you would if you were seeing a physical therapy in person. I would say 90% of our members prefer that, to start with a video visit. And then if we compare with what physical therapists are doing for in-person care, I would say what it looks like is we do an initial visit on video, they would do one in person, and then we probably have more frequent touch points, like more frequent check-ins, and then less video visits or less synchronous visits than you would probably do with your provider in person. But again, it just depends on what the member is looking for. I can say right now, I'm working with a member who is an avid runner, and he's trying to ramp up his running program. And we did a synchronous or a video visit at the beginning to do an objective assessment to figure out where his pain was, what triggered it. And now every few days he sends me updates on the run that he went on, and we're progressing his running program asynchronously. There's just no need for him to jump on a video visit for something like that. And then in a few weeks, I will do a video visit with him and we'll retest the movements that were causing him pain and progress his exercise program and such. But the beauty of the asynchronous is that I'm able to get like real-time feedback from how these people are doing. When I used to see members in person, like at Google or on Meta's campus, sometimes they wouldn't come in for a couple of weeks and they'd have, you know, like notes on their phone of what happened for the last couple of weeks, you know, and I'm not really able to give them feedback on everything that happened because they'd have pages of like, I did this and then I had pain and then they did this next and I didn't have pain, and it just wasn't that helpful because by that point it had already passed, right? Whereas this is a lot more real time, and I can say, you know, I think you pushed that run too much. I think we need to rein it in. Like, you really weren't supposed to be doing hills quite yet. Can we figure out something else to do? And we can progress him a lot smoother back into his running program.
Gotcha. Danna, what's been your experience?
Yeah, so I mean, it's been an interesting evolution in general, just for virtual care. When we launched across over our virtual platform in 2020, just like many others at that time were forced to because of the pandemic, you know, we had this in development from even before that, which was highlighted by the acquisition of Sherpa. And as I mentioned before, Sherpa was a pioneer in the asynchronous messaging virtual space because at that time, 10 years ago, when they did market research, people didn't want to get on a video call. It was something that was a little bit unfamiliar to them. And so it was found that more folks would actually message. And now fast forward, you know, to 2020, everyone knows how to get on a Zoom call. And we found that actually in primary care, a lot more members are asking for video visits instead of messaging. So we pivoted our model to allow the members to choose. And there are some things that members want to get in front of a provider and see their face. There are other things, you know, in particular, maybe sensitive topics that they may not want to discuss with someone face to face, but it's easier for them just to message about. And so what we found is that it's not sync or async. The relationship is really what matters here. So sync or async is just how we choose to communicate, but the member can decide on what's more comfortable for them. And just to the point of what Nicole and James have already said, you know, we find that the depth of messaging and the frequent touch points that you're allowed to do, if someone decides to engage via video, we're able to actually provide a more comprehensive evaluation because of the ability to be able to do both.
You know, Danna, this is that point you made. It's not async or sync. It's about the relationship. This is, you know, as I've been going through this experience myself, it's kind of like explaining to somebody the internet for the first time, right? You like, hey, just do this. Go type in www and then, you know, whatever website, and this world opens up to you. It's just amazing. And now you can do all these things online, and it's hard for people back in that time to understand what the internet was. And again, I've just been walking through my experience with care with John, and you know, I just started a conversation over the last year of all of these things: COVID, the tick thing, the annual physical, he referred me out for an ophthalmology visit. I have never once talked to him via Zoom. It's all been via messaging. And that has been all of my choice. Like, there's a button that says schedule, and I can schedule a time with him. And it's just been so, the relationship has come so natural for me that I'm like, I don't know that that's going to enhance my relationship with John, because we're just going back and forth. And so for me, that's worked. I know that you know, everybody gets to choose their path, and you know, you guys have the flexibility to allow members to choose their path. But for me, that's been tremendously convenient, because you know, accessing a provider, you know, in the community is tough. And for me, I've just found this to be so simple. Okay, let's keep moving. Another big thing that I see out there are these massive benefit ecosystems with, you know, like 100 different point solutions. And it's almost like you get more points the more point solutions you have, which I think is not right. But and so there's you know, the best in class in every single element, versus we're just a comprehensive solution. We've got James, who's doing mental health, and Danna is a full scope primary care doctor, and Nicole's doing physical therapy. We don't have health coaching on this call right now or care navigation, but those are also part of the team. So what's it like working with a care team? Nicole, let's start with you.
Great. Yeah. I love this question because one of the things that really excites me is when the physical therapists on my team come to our team huddles and they say, I had a member that was getting like passed around the healthcare system and we are their final stop. And we see that quite often. It's very common with musculoskeletal issues for patients to get passed around because they come in with knee pain and then they get passed off to get imaging, and then primary care refers them to like orthopedic specialists, and now they think it might be like a rheumatoid issue, and so now they're seeing a rheumatologist and they need labs, and like that person can't order the labs, and they're just like running in circles, and no one wants to diagnose it, no one wants to own their care, no one wants to say what's going on. We would not be able to own all of the MSK concerns we see if we didn't have the backup of this great team, like James's team and Danna's team and our care navigation team. We just wouldn't be able to. But people are able to come through our door, and we're able to be the quarterbacks for all of the musculoskeletal care because we know that Danna is backing us up, able to order labs and imaging, and everything kind of stays within us, and we're communicating with each other constantly so that they're being able to receive really high quality care and really efficient care. And so that's super rewarding, is when people which happens quite often, come in and say, I've seen like 6 different people for this issue. I still don't know what's going on. And we're able to say, okay, this is like the final stop. Like, we got it from here.
That's awesome. Danna, what's your perspective?
Yeah, I mean, I think that, if we're taking care of the whole person, right, they're not just one service line. There's complex issues, and there are a lot of great options out there currently, virtual solutions, but many of them are siloed solutions, so they don't have the level of integration that we do. We're the only virtual primary care provider or primary health provider that's offering all of these components: primary care, behavioral health, PT, health coaching, and care navigation. And I think, what does that mean in terms of the fact that we're offering all of these things? Well, on the backside, right, we are a care team that meets daily. We discuss member cases. We've even had scenarios where I had my primary care doctor and my psychologist get on a Zoom together with a member because there was a lot of things that needed to be discussed in terms of his anxiety and his medication management. And it was more efficient and really had real-time integration when all 3 of them were in the same room together. And I think, we can use the word efficiency, and the challenge is that efficiency is hard to measure. There's not really like a return on investment on that per se, but when you have a combined care team, we see the efficiency that it's provided for our members. And we also see that it's just better care. There's so many contributing factors to a member's health. And whenever we're able to talk about our members and say, oh, I didn't realize that they were dealing with this, or I didn't know that, this was what the lab showed, it's actually helpful for all of our service lines to be part of that.
Healthcare gets really expensive when it gets in silos. I think, there's less information transfer, and regardless of, we get asked from consultants all the time about, API exchanging data, and, that's data. This is why the care team matters, because there's a fabric for taking care of that member. And, it doesn't always come out just in the raw data that gets presented. And so, I appreciate being a part of that care team. James, in the interest of time, I want to advance the next slide. I want to hit this right with you. I know you've been super proud with the rest of the Mental Health Guild about the depth of the quality and measuring that quality. One of the challenges with doctors is that all doctors think they're doing an excellent job, right? And that's because, they're practicing medicine, but you actually have to measure that to know if you're doing a great job. And I'm so proud of the medical group with some of the ways they've come up to measure the care that we deliver and make sure that it continues to be quality. So James, I know you spent a lot of time in this from a mental health perspective. How do you know that you're delivering quality care continuously as an individual provider? And then as a leader on the Mental Health Guild, how do you know the rest of the mental health providers are delivering quality care?
Yeah, and I think you named it, Nate. It's because we measure it. Measurement-based care is a pillar of what in mental health we call evidence-based practice, which means I think that the care that you're delivering in a way that's grounded in science and in research. And what we know is that in treatment, you have to be able to kind of measure and be looking at what's going on for your members as they're going across, to make sure that it's effective, to make sure that not just that it's working, but that they're in agreement with the approach that you're taking. Kind of gets back to the relationship elements, Nate, that you were saying before. If a member doesn't feel, I think, kind of that they're able to collaborate in their care goals, we just know that they're not going to get better. It's one of the clearest, I think, effects that we find in the research literature. And so at Crossover in mental health, we use a program called Tritium, which sends a pre-session questionnaire to members either before their sync visits, or if they're engaging asynchronously, providers can kind of send it at whatever sort of frequency they determine would be necessary. And the really cool thing about this, I guess, from my perspective, is that it's not just that we can track outcomes and we can report, our effect size and how good we're doing in terms of our care outcomes, but on the relationship level, Tritium is something that you and your member can actually look at together in session. Nicole, I think, alluded to this earlier, where you can share screens. You can actually show a member what they're responding, the scores that they're giving, and sort of see how they're progressing in their care. If something is off, if it either, let's just say that their depression's not going down, you can talk about it together and name it and say, hey, what's kind of getting in the way? Or maybe is there a different approach that we need to pivot? If a member's not feeling like that they're fully bought in to the approach that you're taking, that therapeutic alliance measure that we talked about before, a provider can see that in real time and name that and talk about that, with their members. And as a lead, that's sort of the practice model that I want to ensure that all of my team are using with their members, because it leads to the best outcomes and the best care experience for members. So for me, I think when I think of quality, I think of not just that we measure, but how we're using those measurements to inform our care.
Yeah, I've seen some of your dashboards, for the therapist, and it literally rank orders the therapist and how they're performing, and all the providers get to see this, right? They get to see how they're doing against their peers, and the culture that we have here, it's not a punitive ranking. It's a marker of like, hey, how do we all get better? And there is that mission-driven focus here when you come join the medical group of that's the goal. And so having these tools in place that are embraced by the care team is fantastic. We're running. Sorry, go ahead, James.
No, go ahead. I'm sorry.
I was going to say we're running short on time, and I want to get to one last thing that I hear often. And Donna, I'm going to kick this one to you, but oftentimes, whether it's PT or medical or mental health, James, with virtual, the question comes up, how do you transition these people to the community? How do you connect them to the physical experience when you need to, and then get them back? Like, how does that not become another silo in their experience? And so Donna, help us understand how you help that member walk through that when they actually need to have those physical experiences.
Yep. So this is where our care navigators really come in. We harness their power to connect the members to the community whenever it's necessary. Again, we are leveraging the acquisition of Sherpa and their care navigation database that's been built up over a decade. We have the crossover in-person options, which Nate showed on that earlier slide. So if you happen to be located near one of those, we're all one medical group, so we can actually send you there and then still have that within the same medical home. But we have really curated a list of community providers, specialists, facilities, which meet a very strict criteria of just to make sure that they are high quality and low cost. And we've also developed resources for helping to flag any issues with social determinants of health, so including community financial and housing services. Again, we're across the country. We're able to notice patterns to be able to best meet the needs of our communities. And we've been able to flex to notice that if someone's scoring high in financial insecurity in one area, it might be because they need governmental aid, but another area might be because they need help with financial planning. In terms of what happens when we do send you to an outside provider, we always follow up to make sure that we get a consult report, and we follow up with the member to see how they're doing. And then frequent touch points along the way as well. There are members who have primary care doctors that they love and want to continue with, and that's fine. We're very used to working in collaboration with community providers, and often then they may access us whenever they're having trouble getting in touch or getting in to be seen by their usual provider. But it doesn't have to be that you can choose, only one person to be helping with your care. We can actually work in coordination.
Yeah, and I could just add that from a member experience, I've had 2 referrals. One was for labs, which my care navigator, Pooja, totally coordinated for me. I had an ophthalmology visit where, like a typical, idiot in healthcare, I told Pooja, I got this, I'll schedule the appointment. 6 weeks go by, I didn't do anything. Pooja followed back up with me and she said, Nate, just let me help you. And I said, okay, help me. 3 days later, I'm sitting in the ophthalmologist's chair. Like, that's how fast she coordinated the visit. She scheduled it. She got me, she told me where to park. I mean, it was fabulous what she did for me to help me get there. And then, I left the ophthalmologist's office because John had ordered this specialist visit, and John followed up with me. He said, look, your eyes are great. Got the labs back. He's like, you said something really nice about the labs. I can't remember, but it was a great experience. And let me put my sales hat on real quick, to highlight one of the things that Danna was saying from the care navigation model. There's 3 types of navigations that we do. First is that typical to a specialist, like Danna talked about. Second, which she said, but oftentimes get missed, but we connect people to community resources, housing support groups when they may be in the process of being evicted, or addiction recovery programs, or literally the issues that present themselves to us as a primary health team are a lot of the SDOH issues, and we can't ignore those. And so we have to connect them to the right resources and then work with those resources to make sure that our members are getting better. And then the last thing we do is we connect them to the benefit ecosystem, where there's organizations that have been organized by the employer that are really helpful. And so we navigate into those 3 services for the members that access us. So Danna, James, Nicole, you guys are awesome. I really appreciate your time, appreciate the candid responses. I hope that for the people that joined this webinar, this is helpful for you guys to see the care models that are being developed and delivered virtually. I hope this is helpful for you guys to press more into this. We certainly are, as an employer, to be able to deliver this kind of comprehensive foundational primary health approach to all of our employees across the country. And we hope that this is something that you guys spend more time and invest in, because we believe that this foundational primary health model needs to become more adopted for us to be able to get to deliver better care to our members, to improve health, and to reduce the overall cost. So thank you so much. You guys have our email and contact information. If there's any follow-up questions, shoot us an email, and we appreciate your time. Take care.